right, welcome back, and thank you for staying with us as we transition into our health segment this Wednesday, and we really appreciate your company for staying on. And in case you're just joining us, you're just in time for the conversation on Mpox, or better known as monkeypox, depending on what's most popular for you. And the reason we're having this conversation, it's because our very own Ministry of Health has just confirmed that there was a first case that was reported within our borders. Yesterday, a statement from the ministry said that the case was treated and it is now recovering. It's a truck driver that was identified at Port Health by Port Health officers with generalized rash at Taita Taveta one-stop border. This was on July 22nd, 2024, and the individual was identified as having symptoms that was 2 weeks prior to that particular confirmation. So, of course, there was tests that were done at the public health laboratories that detected Mpox. That was on July 29th, 2024, and validated by other reference laboratories in the national laboratory network. So now it's confirmed. But then again, it's no cause for fear, but because the ministry has said there's a lot that has been done in terms of surveillance. But the reason we are having this conversation is to understand this. When we talk about Mpox, what is it all about? And I have with me an infectious disease specialist, a consultant at the Aga Khan University, Professor Rodney Adam. Thank you so much for creating time for us.
And thank you.
And karibu to the show this morning. Yeah, so beginning from the very basic, first of all, this news of a confirmation of a first case within our borders, how should we look at it? How should we receive it from your perspective?
Well, that's a good question. The current outbreak has been going on in DRC since the beginning of January last year, and there they have had more than 20,000 cases and 1,000 deaths. So it's now throughout much of the country, and probably should have resulted in more international attention long before, but unfortunately what happens in sub-Saharan Africa is often ignored until it moves into Europe or North America. And that's part of what has happened here. So now that there is spread within the country, it's mostly human-to-human transmission now, and it's extended beyond the borders, as we know, in a few cases in the surrounding countries, such as Rwanda. So, are we completely protected from it? No. It could certainly come here, and we have to be ready for it. We don't have to panic at this time, but we do have to be prepared.
Mm-hmm. So it's not a news that we should take with a pinch of salt. We actually need to be alert and take more precautionary measures as a country. I want us to understand, is it a new thing, or it's something that has been reported elsewhere outside even Africa, sub-Saharan Africa before?
Yes. So if I can go a little bit into the history, the virus is called monkeypox. Now many prefer Mpox, but it was discovered in Denmark in a monkey in 1958. So that was a research monkey, and presumably that monkey was accidentally infected, because monkeys are not the true reservoir. The true reservoir is either some kind of rodent in the endemic area. It's not known exactly which one yet, but that's the most likely scenario. So the human in the past has been sort of the accidental host, and then there's been transmission a few cycles within humans, and then those outbreaks have died down. What's different here is more sustained human-to-human transmission. So I think right now the role of the wild animals is nil, and we're talking about the human-to-human transmission.
It's good you've said the accidental infection of the monkey, because one of the questions that, just out of curiosity, does it come from monkeys? That's why it's called monkeypox. So where does it come from?
So it's from the the rodents as some type of contact results in human infection. That's the going idea as of now. Monkeys never have been a part of the whole chain of transmission.
All right. Is it related to smallpox or chickenpox? Just if you run us through even, the virus itself.
Yes, the monkeypox is rather closely related to smallpox. And in fact, that's probably why it wasn't really recognized until 1970. Because before that time, and without nearly as sophisticated diagnostic tools as are available now, those were probably assumed to be smallpox cases. And in fact, the smallpox vaccine has pretty good protection against monkeypox. Not 100%, but even people who had been vaccinated for smallpox many years ago have some level of protection. So yes, those two are related. The chickenpox is not a pox virus. It's a herpes virus. So biologically, it's not related to smallpox.
All right.
But it can look like it. So when there's a bad chickenpox case, it can be thought maybe this is a monkeypox case.
Well said, Prof. But then, now that you've told us that, how then do you differentiate, these types of poxes, for lack of a better term? Let's talk about the symptoms of monkeypox that would make you make that diagnosis or even suspect, the need for further tests for monkeypox.
Yeah, that's a good question. And early on, there is a period before the rash where there's you might even think it was influenza from the symptoms before the rash starts. But then the rash will generally start in the face and spread to the remainder of the body, including the palms and soles of the feet. So the rash is different, but the challenge comes when the severe chickenpox, the abnormal chickenpox, can look a little bit similar to the monkeypox. And when that happens, there should be a clear diagnosis obtained so that we know for sure.
So is there any even physical examination or something that you can see and tell, this is a clear-cut difference, this is something that would lead us to suspect that it could be monkeypox, and not anything else?
Yeah, ultimately, you'll have a strong suspicion that it's one or the other based on the appearance and progression of the rash, which is much more of a raised lesion in monkeypox than in chickenpox. But for the individual cases, there sometimes will be this doubt, well, I think it's this, but not sure, and that's where you need the diagnostic testing.
Talk about the vulnerabilities in terms of the demographic, who is more at risk and who is not, and do certain regions show a trend of being more vulnerable compared to others when it comes to the trends of transmission of monkeypox?
I'll answer that in several parts, and I'll come back to a little bit of more of the history of monkeypox. So there are two different forms of monkeypox in Africa, the Central African and the West African variant. The Central African has a higher mortality rate. People are more likely to die, and now it appears that the major transmission for that has become human to human by close contact. The West African variety is the one that was brought to Europe, I believe initially Portugal and then Spain, UK, and to the US as well. And that was primarily sexual transmission. And in fact, as those areas of transmission were interrupted, that has mostly died down. The big concern now is the Central African variety, which is what we're dealing with, where the center of it is DRC and throughout the country. The age-wise, it's younger people who are at higher risk, especially children under 5. The mortality has been higher there than in adults. We can also assume that people who are immunocompromised, such as untreated HIV, will be at greater risk as well.
And is there, something that you mentioned something about? Cases started being reported as early as January, and it has taken like a season of silence on this particular subject. Now that it is being escalated, and you mentioned, it not being taken seriously. Probably, is there a reason or that you feel probably this may have been kept under the law for a while until now? Why it's a global issue like we saw the COVID-19 pandemic, and it was blown and everybody was suddenly on their toes trying to manage it? Would it have been treated differently if it was like a global crisis suddenly, as opposed to just happening in sub-Saharan Africa?
Well, first of all, it was actually January 2023 that this outbreak started, so it's been well over a year. And yeah, I think there is a tendency globally to say, well, this is just happening in Africa, it's not relevant to this place. And we've seen that for other kinds of infections as well, but with less consequence than certain ones. Even going back to Ebola, which is much more serious, there were numerous small outbreaks before the large outbreak of West Africa started, and it was only with that large West African outbreak that countries in Europe and North America started becoming concerned. So I think that's part of what we're seeing here. All of a sudden, we've seen that it can go outside the continent, and it's getting a lot more attention elsewhere.
Does this concern you as a specialist in, for instance, the area of infectious diseases? Does it weaken our effort to manage it better if we take more time to respond?
Frequently that is the case, and in this case, for example, it may be that a more aggressive immunization campaign, if it could have been implemented, would have controlled the outbreak within DRC.
All right. I want us to talk about you've talked mostly about human-to-human transmission, and this becoming the more obvious trend that we are now picking up. Talk to us about that. And when we are talking about Mpox, is it transmittable? If yes, how? And then talk to us about some of the safety precautions that probably any person who's watching us this morning need to be aware of if they want to stay safe or to keep their loved ones safe as well.
Well, the mechanisms of transmission are varied, and the big outbreak in Europe was primarily sexual, which means that it was mucous membrane to mucous membrane, damaged skin to damaged skin, or something like that. It's maybe more appropriate to say related to intimate contact. What's happening now in DRC with a large number of children being infected, it's probably still close physical contact for the most part. Again, skin to skin, mucous membrane to mucous membrane. But is there more casual transmission? That's not quite as clear. If a patient is in the hospital, they will have more full isolation procedures that look for droplet transmission, but what we know is that mostly it's the more intimate interactions that result in transmission.
Skin to skin, that's also something you mentioned?
Yeah, if it's intact skin, not as much, but if it's skin that already has a skin rash or something like that, then that's a potential means of transmission.
All right, so that gets me to the second part of my question. What do you think would be the most ideal safety precautions before even we get to the national level and the surveillance that needs to be put in place on an individual capacity? What are some of the safety precautions that we need to be concerned about or even implement so that we avert further spread?
That's a bit hard to answer because it's so dependent on your setting, whether you're talking about in the school setting or within families. Mm-hmm. So maybe if you can pick one to explore.
Looking at let's talk about public areas where we share the spaces, we share the environment, and even school is considered a public area where so many people come together in a crowd somewhere. We share public transport, we share spaces in the market. So how do we handle ourselves in the public spaces to avert any possible spread of the Mpox virus?
That's a tough one because right now, we don't have any evidence that we have indigenous transmission mm-hmm. within the country. Mm-hmm. So that means when you go on the matatu or whatever, anybody you touch, anybody you come in contact with is not going to have Mpox. Mm-hmm. But now let's suppose we have ongoing transmission in the country, then it looks different. And some of those precautions will increase. Mm-hmm. So it's a little hard to give a blanket statement now when we don't have evidence of endogenous transmission, mm-hmm. Whereas if we do, then we will have to start revisiting some of those public interaction places. And schools will be probably a bigger issue than they were during COVID because children didn't get very sick from COVID. Mm-hmm. In this case, they're actually more vulnerable than the adults around them.
Mm-hmm. Mm-hmm. Let's talk about, the reasons we made very good progress with smallpox was the introduction of the vaccine that has led us to become at least a bit protected, if not completely. Do we have a vaccine for Mpox yet? And if you put that in the context of Kenya, are we there yet? Do we have it within our borders, and is it already being administered?
Yes, so the smallpox vaccine has a high level of protection against monkeypox as well. Mm-hmm. And in the European outbreak, the smallpox vaccine was used for sort of ring protection of people at high risk of exposure. So, and then there are new vaccines in the works that I believe are being starting to become available. I don't have any details on those other options, but there clearly is a vaccination strategy that is available and would be something to pursue if we start having transmission within the country. Mm-hmm. In terms of availability, I would defer that question to Ministry of Health. Mm-hmm.
Mm-hmm. But they are there already. There's work that
there are vaccines that are out there.
All right. I want us to talk about treatment, whether this is treatable, but let me just run you through and run our viewers also through some of the measures that the Ministry of Health in their statement yesterday said that they have taken just to be able to step up their surveillance also, and of course just to avert any possible spread if there could be. One of them includes the deployment of a rapid response team to support the affected counties with detailed investigations. Of course, we are talking about the counties around the border where this case was reported, and of course also activated public health emergency operation centers across the country. Incident management teams have also been established to coordinate response activities. The ministry has also been monitoring the evolution of the outbreak in the neighboring countries to assess the risk of regional transmission and appropriately adjust the response within Kenya. Counties have also been advised to sensitize the public on the outbreak and requisite preventive measures necessary to be taken to avoid contracting the disease. There are also guidelines issued on handling disease, including frequent hand washing using soap and water. And of course, emergency hotline numbers that have been provided for the public to report any suspected cases. Key among the counties that have already begun escalating these efforts include the county of Busia. This is where the deputy governor in the county executive for health actually said that surveillance has been escalated to just sort of reinforce what the national government is doing. Remember, this is one of the counties that actually are close to where this case was reported. But Prof, I'm looking at the sensitivity of moving from one region to another. This looks like it's sort of like a cross-border threat. From your own, judgment and analysis, in terms of surveillance and even protective mechanisms, what do countries need to do? Because for this case, for instance, moving from one country that was, I'm trying to look at the route that he used, traveled through Uganda, Kenya, Tanzania, and Rwanda. So if there was any sort of contact tracing that needs to be done, it should be done within all these countries. So it's no longer just a Kenyan issue. We're also talking about this outbreak being reported from DRC and other neighboring countries like Rwanda, Uganda. So it's like sort of like a regional health threat. So how do we work in these complex circumstances to make sure that we are not just taking care of ourselves, but what is happening elsewhere as well?
Yeah, that's a very good set of questions that'll go deeply into public health measures, of course. Mm-hmm. One of the things to emphasize is that even cases coming across the border may not be recognized when they cross. Mm-hmm. So they may seek medical care in Nairobi, Nakuru, Kisumu, and wherever. So I think throughout the country we have to be ready to recognize and diagnose those cases. Mm-hmm. And then after that, of course, to go through any potential contacts mm-hmm. for exposure. On the healthcare side, we have to be extra vigilant to take appropriate precautions without we don't want to leave the patient without care. We just want to take proper precautions for the healthcare workers and to take good care of the patient, and that can be done. For the people coming across the borders, of course, I assume the ministries of health will be in contact with each other about those cases and tracing them as necessary. But truck driving has long been a way of spreading infections across the globe. That was notable during the early days of HIV, of course. You would see the cases along the truck routes. Mm-hmm. If you were to compare, as an infectious disease expert, over time you have seen trends such as this, which one would you say was the worst? For instance, COVID and what we are now witnessing, if you are to compare in terms of severity, is there any worse or better, or sort of like compare the two evils? It's hard to compare them. COVID was, especially after the first two waves, was highly contagious, mm-hmm. and there were no containment efforts that would have made a difference after that. So, and I think that was finally recognized that whatever we do wouldn't make a difference. The hospitals were filled with the first at least 3 surges, and I doubt that's going to happen with monkeypox. But then with COVID, everybody had it within the first less than 2 years. So after that, all the infections were mild, and now that's sort of a thing in our past. Mm-hmm. We're not going to see that with monkeypox. If we have sustained transmission, then our best tool, I think, will be an immunization campaign. Mm-hmm. 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 So they're very different. I'm not sure how to say if one's worse than the other. Which one, sort of like saying which one is a better evil. Let's talk about
the diagnosis, how is it specifically done? Because we've talked about the healthcare workers also being, right now, one of the things that needs to be done is to ensure that whenever a person presents themselves to the nearest health facility, they can be able to detect that this could be a suspected case of monkeypox. So how is the diagnosis done, this test, to be able to establish that this is monkeypox?
Yes, the best way to make the diagnosis is with a PCR test. And it's from, when they have a rash, it's from one of those lesions. And that also works for chickenpox. It's a different test, but the same kind of sample. So anybody with a rash that you think is monkeypox, you also do a PCR to diagnose chickenpox. In fact, we had a case like that, I believe it's been a couple of years ago at Aga Khan, where there was suspected to be monkeypox. It turned out to be a severe chickenpox case. Mm-hmm. So the diagnosis is made and then you deal with it accordingly. In fact, the infection control practices within the hospital right now, the advice is that you do precautions that will protect whether it's chickenpox or Mpox.
Mm-hmm, mm-hmm. All right. So in terms of treatment, because that is the other area people would be really interested in knowing, do we have a treatment for Mpox yet?
Well, first of all, supportive treatment is key. That's probably going to make the biggest difference. And it may be that that's why the mortality rate has been as high as it is in DRC, because many of these people are from areas with much lower levels of health care available than what we have in Nairobi and throughout the rest of Kenya. So supportive therapy is the first and most important thing. There are antivirals that are, you could call them experimental at this time. So they might work, but we don't have good information on what their efficacy would be.
Mm-hmm. So there is no like a clear-cut treatment that you can say that this is the treatment for Mpox?
You are correct.
Yet, yeah?
That's correct.
So what's being done, like, even in the area of research, what needs to be done for us? Because even during COVID, this was like the same dilemma we were facing. There was it was just management, try this, try that. There was nothing really that you could say this is like the treatment for COVID-19. Mm-hmm. Similar to other infectious diseases that probably we have experienced here in the country and even elsewhere. What needs to be done in the area of research mm-hmm. so that we sort of like understand these new trends of infections that we come across as a globe?
Yeah, good. You're asking great questions.
Thank you.
Now for COVID, most of the disease was from the body's immune response. So there were several treatments and none of them were more than 20% effective. And some of the best ones were actually inhibiting the immune response. That's not going to be the case for treating monkeypox. So the antiviral drugs may turn out to play a very important role. Also, with monkeypox, it is likely that immunization, even immediately after exposure, will be effective at either eliminating or reducing the severity of disease. So we will probably have options related to immunization. And I think in this case, that will have to be the bigger component of the armamentarium, mm-hmm. and where antiviral treatment will be more secondary.
Mm-hmm, mm-hmm. There's been a concern, the reason I asked that question is because there's been a concern about the lack of investment and even focus on creating an enabling environment, especially in this side of the world, for us to have our scientists to really break even when it comes to the level of research that they put in place to be able to make a breakthrough in some of these issues. Do you think that's a concern that you feel from your end as specialists, probably?
I think that's a big concern. Mm-hmm. And some of us have actually been discussing for many years that Kenya should be putting money into funding research and to allow the growth of investigators. Of course, now with the current budget crisis, we're not likely to see that for a while, but I think for the long term, Kenya, from the government side, needs to put more money into funding research. It can't depend totally on outside money coming in. When you fund from the outside, then you also call the agenda, and it may not be the same as what the country really wants.
Kenya and most of the countries in sub-Saharan Africa, because it's sort of like we bear the biggest brunt of some of these diseases. You're saying that the variant, is it the Central Africa variant is more severe compared to the Western one?
That's correct.
So seems like we are sort of carrying the weight of the impact. And if you compare this to even other diseases, it's sort of like this side of the world carries like the biggest weight of the impact of some of these diseases. So no wonder we need to rethink where our priorities when it comes to investing in health and all that in research. I want us to talk about, at least so far, at least for Kenya, we have not reported any deaths. But what are we confronting in terms of the severity of this virus, the Mpox virus?
Yes, it's less severe than Ebola, but it's more severe than COVID in terms of the deaths. So it's somewhere in between. The estimate is for adults, and this is in areas with very limited care available, is somewhere around 3% in adults. But once you get down to children under 5, it's more like 6 to 8%. So that's 6 or 8 out of every 100 who would die from it.
So children are actually more vulnerable compared to the adults. I want us to talk about concerns that have been raised with regards to whether the severity of the impact of this virus and other viruses that we have experienced in the country could be emanating from our lack of if you look at our hospitals, the lack of investment in the right equipment, the right people, and all that. It's not about the virus being severe, but it is about what we are doing to be able to deal with the virus. Because if you see the same virus and how it's impacting other countries elsewhere globally, the impact would be a bit minimal. So the problem may not just be the virus, but how are we managing this virus? Do you think that's also a conversation that probably we should be opening up?
Absolutely. Now you're on quality of medical care.
Yeah.
And we would like to see the highest level of quality obtained, of course. And some of that quality can be done without a huge financial investment. Some of it is expensive, but many things can be done at a higher level of quality by a real emphasis on quality improvement, quality control. So yes, I'm glad you brought that up.
Okay. So, Prof, I want us to talk about, the need for us to also rethink our strategy when it comes to the people that are handling this. For instance, when I was trying to look for somebody to come and break this down for us on the show, trust me, it was a bit of a struggle. For me, I interpreted that to mean we don't have enough experts on these developing diseases that we're dealing with right now. What is it that could be the challenge? Is it the lack of accessibility of these technical courses, or is it something else, lack of interest, or what is it that could be a hindrance for us as a country from having enough experts that we'd want to have? Because at such a time, we need enough of you to be able to be telling us what right thing we need to do as a country to get it right.
Oh, you're hitting something that I'm really passionate about. So, and that's that the whole area of postgraduate medical education. Kenya is producing a lot of medical student graduates now, but what do they do when they finish? They go through internship and then they're out practicing, and probably that's only 10% who will be able to do anything beyond that in terms of training. If you look in the high resource areas, North America, Europe, almost everybody is going through a postgraduate medical training course of some kind. And Aga Khan was started now about 20 years ago here in Nairobi with a primary emphasis on postgraduate medical education. And for a certain number, that is paid for by the hospital. Elsewhere, there's no fund to pay for it except what comes from either the national or the county governments when they sponsor it. So I would love to see a greater emphasis on postgraduate medical education. Mm-hmm. And in fact, the literature now has sort of switched the whole emphasis from availability of health care to availability of quality health care. Mm-hmm. And one of the ways we can do that is by high quality of postgraduate medical education. Mm-hmm. At Aga Khan, in addition to the primary specialties like surgery, internal medicine, pediatrics, now we have a growing number of the subspecialties available, including infectious diseases. And we started that training program, I think it was 8 years ago now, and we have several other subspecialty training programs where we would like to do exactly what you're talking about, is to grow that level of qualified professionals who have the greater depth of understanding.
Mm-hmm. So could the issue then be partly attributed to cost? Do you think
yes.
cost is an issue as well?
Well, somebody has to pay for the training. Mm-hmm. If you graduate medical students, they pay tuition and generally cover the cost of going there. But for postgraduate training, most people are not able to pay the cost, so the funding has to come from somewhere. Mm-hmm. In the U.S., that's covered by Medicare. In the UK, I believe that's all from the NHS. Here we don't have such a mechanism, and so I would like to see that as a high priority. How are we going to increase the availability and quality of postgraduate medical education?
Mm-hmm. I've also heard about, the concern that we seem to be like a hub of medical experts when it comes to the numbers of those we export to go and offer their service elsewhere after taking years of investing and training them, and they get to go out there and serve in other countries. Yet, like I said, we bear like the biggest disease burden on this side of the world. Question then would be, are we producing more than we need, or what is it that we are missing, Prof, if you look at that particular arrangement?
Yeah, the whole brain drain question is a huge one.
Yeah.
And I hope that at Aga Khan we don't contribute to that by sticking to a high level of training. Most of our graduates are staying within the country, so that's the good news. Not everybody's going to stay. And in fact, I think right now we are losing more nurses than doctors because the pay discrepancy is less in Europe and in North America than it is here. So nurses are going abroad for financial reasons. Mm-hmm. So it's going to happen. There's no way to keep it from happening at all.
Does it come at a price? Do we pay a price for it, losing our
Sure.
workforce to other countries?
We do.
Uh-huh. What's the price that we are paying if we are not careful, because this is actually exactly what is happening. I've hosted heads of unions of healthcare workers here before on this show, and the concern has been, yes, that we are churning experts out of universities annually, but we are still years later talking about the shortage of healthcare workers in our hospitals, shortage of experts, like even we are talking with you right now about people who are specialized in various areas. We have a big shortage of those. So what price are we paying for our lack of, being sensitive to this particular discrepancy when it comes to deployment of our health workforce?
Well, in terms of number of shillings, I have no idea. But in terms of comparing what it is with what it could be, if people were staying or if the first direction, then yeah, it is a price. But the shilling amount, I don't know.
All right. I want us to talk about, back to what you were discussing on Mpox. If you were to compare, what has happened within the 2 years that you say there was a trend of escalated cases of being reported, not just in Kenya. Kenya actually just the other days when we reported our first case, but neighboring countries have been reporting cases. If you look at what has taken place within those 2 years as a specialist, do you think it's adequate and there's a genuine effort towards containing this virus from further spread? And what would be your advice on probably what else could have been done that probably was missed?
Yeah, within DRC, I think the control efforts have been very difficult because of civil war, and it appears that the eastern part of the country is very much separate from the western part of the country in terms of any kinds of public health efforts. But likely we in Kenya should have been paying more attention and asking the question earlier, what are we going to do when it moves into Kenya? And I think it's looking now that that's a much greater likelihood as it has spread into North and South Kivu, where it probably is more contagious and a bit closer to us, and with the greater potential of coming in through Uganda, Rwanda, Tanzania. So I think one of the keys will have to be having an immunization plan in place, perhaps healthcare workers, being ready to expand the immunization when there's exposure to individual cases.
And this immunization campaign, which kind of the population should it target? Is it the young who are more vulnerable? Is it the old? Is it the healthcare workers who are like the frontline soldiers of this? Or how should it be distributed?
Good question, probably more from the public health side, but I think you would start with healthcare workers and have some for post-exposure immunization or potential contacts. But then if you were going to roll it out more broadly, and I don't know if that's going to happen or not, but if you were, then starting with younger children would make the most sense, because they're the ones who are most vulnerable.
As I was prepping for this program, Prof, interacted with one a piece of information that was talking about the area of vaccine, and I believe it's in the US there's a vaccine, but then what has been approved as per now is that this vaccine is being administered to people who are above the age of 18, but concern about monkeypox is how it is deadlier to children compared to the adults. I don't know what would be your thoughts when it comes to having such a deadly virus that affects children more, yet the vaccines that are in the market are currently just approved for the adults. So parents are concerned. So where does that leave us? How would you look at that particular scenario?
Well, approvals can change quickly based on evidence. And if we go back to smallpox immunization, that was happening for babies. And in fact, that very same vaccine would be quite protective from monkeypox as well. and in fact, for the smallpox vaccine, the greatly publicized adverse consequences came in young adults. Mm-hmm. The story was that, at least from the U.S. side, was that military recruits, even after the eradication of smallpox, were being vaccinated. And then early in the AIDS epidemic, there was the occasional person with advanced HIV who was given the smallpox vaccine and had devastating consequences. Mm-hmm. So in children, it had been used for decades successfully for babies. So I think it would make sense to start exploring moving back that direction.
Mm-hmm. Mm-hmm. All right. I want us to just remind our viewers, just in case you're wondering, where are we at when it comes to the monkeypox, issue? And this is the latest we know, at least for now, from the Ministry of Health. We have information that the ministry has confirmed one case of monkeypox within our borders, and this was a case of a truck driver who was identified at by port health officers with a generalized rash. This was at Veta one-stop border post on the 22nd of July 2024, and this individual had recorded some symptoms 2 weeks actually prior to this particular incident. And of course the ministry confirms through the PS Mary Mudhoni that the patient was isolated at the Taita Taveta sub-county hospital, where clinicians suspected that either it could be chickenpox or it could be Mpox. Like we were talking here with Prof, the two could actually be confused, but what he said was more related to the Mpox was the smallpox, not necessarily chickenpox. But then again, according to the PS, there was that suspicion that it could be either, because they correlate when it comes to symptoms either way. But then again, after tests were done at the public health labs, and of course these tests were validated by cross-referencing that was done across different labs across the country, it was confirmed on the 29th of July 2024 that it was Mpox. And of course, so far, according to what the ministry is saying, that the patient is fully recovered. But this has not left them just to bury their heads in the sand. There are quite a number of measures that they are put in place, deploying a rapid response team to support the affected counties with detailed investigations, activated the public health emergency operation centers across the country. The ministry has also, put in place the incident management teams that have been established to coordinate response activities. There's also the monitoring evolution of the outbreak in the neighboring countries. We know that this has been recorded in other countries like the DRC, Rwanda, Uganda, and of course also concerns about the patient that was confirmed here in Kenya moving through Uganda, Kenya, Tanzania, and Rwanda. So looking at also what is happening, not just in Kenya, but in other countries as well. Counties have also been advised that going forward, you need to sensitize the public. And that's what we are doing here on Daybreak this particular morning, to help you understand what this virus is all about and what you need to do going forward. So those are the few guidelines that the Ministry of Health has given in terms of the measures that they have undertaken to do this. And of course, there is an emergency hotline number that in case you will have a suspected case near you, you can be able to call. You can check that also on the website of the Ministry of Health. But here in studio, just to break us down for us, to give us the basics of the monkeypox and the Mpox, I have been having a conversation with Professor Rudney Adam. He's a consultant infectious disease specialist at Aga Khan University Hospital. And as we close this conversation, Prof, do we need to be scared? Is there a cause for alarm? When somebody sees Mpox, it's been recorded in Kenya, there was a lot of scare, fear here, there. Do we need to be scared or worried as your closing remark?
Being vigilant, yes. Being worried, no. Yeah. We have other infectious diseases that will continue killing more people than Mpox would, and we need to be vigilant for all of those. We have things that we can do regarding Mpox, and we should be doing them. I think that's the message, not to be excessively worried.
No cause for alarm, but we need to be vigilant. Thank you so much for saying that. That has been Professor Rudney Adam, a consultant infectious disease specialist at the Aga Khan University Hospital. We really appreciate your company as well for creating time for us this particular morning as we were having daybreak this morning, and for your contributions and efforts to just make this show a success. My name is Safina Chengoma. Allow us to wrap it up there. Have a lovely day ahead and enjoy the rest of your viewing.